All right, deep divers, grab your notebooks because today we're embarking on a journey into, well, one of the most dynamic and sometimes challenging areas of medical study, pediatric skin conditions.
Absolutely. It's a big one.
Yeah, and we're pulling all our insights from a key chapter in Understanding Pathophysiology, that essential 7th edition by Huther, McCants, Brashers, and Rote.
A classic text.
It really is. Our mission today, to kind of distill the core knowledge, unravel the complex mechanisms, and bring those crucial clinical examples to life.
Yeah.
We want to make this material not just understandable, but genuinely engaging, whether you're, cramming for an exam or just seeking a robust shortcut to expertise.
And what's truly illuminating about this particular chapter is how it doesn't just list facts. It actually builds a foundational understanding of why certain dermatological issues manifest in children the way they do. For anyone in healthcare, truly grasping these concepts from a pathophysiology perspective is, well, it's empowering. It sharpens your diagnostic eye and prepares you to differentiate between, say, a simple rash and something that needs more urgent attention.
That sets the stage perfectly for our deep dive.
Yeah.
And speaking of foundational, let's kick off with a condition so common. I mean, almost everyone has experienced it or knows someone who has acne.
Oh yeah, acne vulgaris.
Exactly.
Yeah.
Now, what many might not realize is that acne vulgaris isn't just about surface-level pimples. It's actually the most prevalent skin disease, primarily affecting those between, 12 and 25.
That's the main age group, yeah.
And it really seems to have a family connection, like genetic susceptibility significantly influences how severe it gets. What's the deeper story behind this really widespread challenge?
It's fascinating because to truly understand acne, you really have to go right down to the microscopic level of the skin. The whole process starts within these structures called pilosebaceous units.
Pilosebaceous units.
Okay. Yeah, think of them as tiny, specialized sort of mini organs found most densely on your face, upper chest, and back. Each unit has a large sebaceous gland that's the oil producer,
Got it.
a small, almost invisible vellus hair, and a dilated follicular canal that's visible to us as a pore. It's essentially a small, oil-producing hair factory.
So it's not just a generic pore, but this whole specific structure designed for oil production that then kind of goes awry.
Precisely. And that's where the two main types of acne lesions come in. Non-inflammatory and inflammatory.
Okay.
So non-inflammatory acne is where we see comedones. You probably know these better as blackheads, those are the open ones, or whiteheads, which are closed comedones.
Right.
They form when accumulated skin cells and sebum, oil, distend the follicle. They basically stretch it out and block the opening.
Ah, okay. So the blackhead isn't actually dirt. It's more like oxidized material at the surface of an open pore, and the whitehead is still trapped under the skin.
We got it, exactly. But things get more complex with inflammatory acne, sometimes called cystic acne.
All right, the more severe kind.
Yeah, this type usually develops from those closed comedones, the whiteheads. What happens is the follicular wall ruptures, it breaks, and it expels all that trapped sebum and cellular junk into the surrounding dermis.
Ouch.
Yeah, and this signals an alarm to the immune system, triggering an inflammatory response. Now, if this inflammation is near the surface, you see pustules,
Okay.
but if it's deeper down, you get those painful papules and cystic nodules, and these are the ones that can lead to significant scarring. It's also really important to note that both types, non-inflammatory and inflammatory, can exist side by side in the same person.
Okay, that makes sense.
And a key player in this whole process is a bacterium called Cutibacterium acnes. It used to be called Propionibacterium acnes.
Oh, right. I remember that name change.
Yeah, and it contributes to both the follicular occlusion, the blocking, and the subsequent inflammation. So it's a true microscopic battle going on there.
Wow, that really paints a much more intricate picture than I think most of us, grew up believing about pimples. Okay, so from that internal battle within the pilosebaceous unit, let's maybe turn our attention to conditions where the skin's outer defense is compromised. What's the first thing that comes to mind when we talk about atopic dermatitis, or AD?
For me, it's the sheer intensity of the pruritus.
Pruritus. The itching.
Yeah, severe itching. That's really the defining characteristic, the
Yeah.
hallmark symptom of AD. You'll often see it accompanied by a very specific eczematoid appearance, redness, swelling, what we call edema, and scaling. It's an incredibly uncomfortable condition for the person experiencing it.
So the itching isn't just a nuisance, it's actually central to the whole problem.
Absolutely. Fundamentally, the skin's natural barrier function in AD is inherently impaired. Think of healthy skin like a well-constructed brick wall, right? Keeping irritants out and moisture in.
Okay.
In AD, it's like some of those bricks and the mortar between them are missing or faulty. This makes the skin dry, itchy, sensitive, and just easily irritated.
So it's leaky, basically.
Exactly. Leaky is a good way to put it. And the constant rubbing and scratching, which is almost an uncontrollable reflex to relieve that intense itch, actually damages the skin further, leading to many of the visible changes you see. It's this relentless itch-scratch cycle.
Ah, the cycle.
Yeah. And if you were to imagine figure 44.2 from the text, you'd picture characteristic lesions, maybe with some crusting from all that irritation and scratching, often quite prominent over the knees and around the ankles in the image. That visual truly captures the classic presentation.
That connection between the physical barrier, the leakiness, and the neurological sensation of itching is, wow, it's a profound insight. And does the way this leaky wall presents, does it change as a child gets older?
It certainly does. The rash distribution changes pretty significantly with age. In very young children, infants and toddlers, you'll typically find it on the face, the scalp, the trunk, and importantly on the extensor surfaces that's the outside, like the fronts of the knees and backs of the elbows. But as children get older and into adulthood, the rash tends to shift to the flexural areas. So commonly found on the neck. In the antecubital fossae, those are the inner elbow creases.
Right, inside the elbow.
And the popliteal fossae behind the knees, as well as on the hands and feet.
Interesting shift.
Yeah, and this impaired barrier also means individuals with AD are unfortunately more susceptible to secondary infections, viral, bacterial, or fungal, setting up shop in those eczematous areas.
Makes sense. The defenses are down.
Exactly. Diagnostically, while there aren't specific lab tests for AD, you often see things like increased serum immunoglobulin E, or IgE levels. Those are allergy antibodies, along with eosinophilia, which is an elevated count of a specific type of white blood cell, often linked to allergic reactions. Plus, they might show positive skin test results to various common allergens.
So it's really not just a skin condition in isolation, is it? It feels like a systemic immune response, almost like an internal warning system that's kind of gone haywire.
That's a great way to think about it. It definitely involves the immune system significantly.
Okay, so from that often chronic, sometimes hereditary battle with AD, let's maybe pivot now to another entirely different challenge. The highly contagious, but often benign, world of viral skin invaders. Let's talk molluscum contagiosum. What should we know about this distinctive condition?
Right, molluscum contagiosum. This one is caused by the molluscum contagiosum virus, or MCV. It belongs to the pox virus genus.
Loctavirus, like smallpox.
Well, same family, but MCV is a much, much milder cousin, thankfully. The virus has a pretty clever way of multiplying. It proliferates within the follicular epithelium, basically the cells lining the hair follicle. This induces the epidermal cells, the skin cells, to grow downwards into the dermis, forming these little saccules that get packed with viral clusters.
So the virus basically hijacks the skin cells and makes them build these little viral factories, creating those unique bumps we see.
Exactly. That's a perfect way to describe it. This leads to the characteristic molluscum body, which is essentially a collection of mature, immature, and incomplete viruses, along with cellular debris, all packed together. If you picture figure 44.7 from our text, you'd see these discrete, slightly umbilicated, meaning they have a little central dimple or depression, dome-shaped papules.
Ah, the little dimple is key.
It is quite characteristic. They're typically small, maybe 1 to 5 millimeters in diameter, and can pop up anywhere on the skin or even the conjunctiva of the eye. In children, you most commonly find them on the trunk, the face, and the extremities.
Okay.
And a key insight here is that these lesions usually aren't inflamed unless they get traumatized, by scratching or if a secondary bacterial infection sets in.
Right.
And while they generally resolve on their own over time, scarring can occur, especially if they've been picked at or become really irritated or infected.
That's incredible how such a tiny virus leaves such a specific, almost signature mark with that umbilication. And speaking of viral signatures, let's look now at 2 viral rashes that, well, historically defined childhood for many generations, rubella and measles.
Ah, the classic exanthems.
Exactly. These are conditions that, thankfully due to modern medicine, many people might only know through vaccine campaigns these days.
You're right. It's really a testament to medical science and public health. Let's start with rubella, often called German measles or 3-day measles.
Okay.
It's caused by an RNA virus that enters the bloodstream, usually through the respiratory route. It's generally quite a mild illness in children with an incubation period of about 14 to 21 days.
So 2 to 3 weeks.
Yep. The early signs, the prodromal symptoms, can be pretty subtle. Maybe enlarged lymph nodes in the neck and behind the ears, a low-grade fever, headache, sore throat, runny nose, maybe a cough. Not unlike a mild cold.
Yeah, sounds very nonspecific. So if you just saw those symptoms, you might not immediately jump to rubella. What's the distinctive visual clue?
That's where the rash comes in. If you imagine figure 44.8 from the text, you'd see a faint pink to red, somewhat coalescing, meaning the spots kind of merge together, maculopapular rash.
Maculopapular, so flat
Choshi.
spots and small bumps.
Exactly. It typically begins on the face, then spreads downwards to the trunk and extremities, usually appearing about 1 to 4 days after those initial flu-like symptoms. This rash is a direct result of the virus actually reaching the skin.
Okay.
It's typically quite mild and fades after just 2 to 3 days, usually without any major complications. And interestingly, children are generally not contagious anymore once the rash actually develops.
Huh. And the prevention story for rubella is, well, it's a powerful one, right? Tied directly to the MMR vaccine.
Absolutely. Rubella vaccination combined with mumps and rubeola or measles has led to its near elimination in the United States. It's incredible.
It really is.
But this isn't just about individual health. It's a powerful demonstration of collective immunity or herd immunity and also the fragility of these public health achievements. Unfortunately, we still see challenges globally and even in developed countries, with outbreaks often linked to things like international travel and clusters of unvaccinated individuals.
Right, the pockets of vulnerability.
Exactly. And it's so crucial to reiterate this point. Extensive studies, massive studies, have unequivocally concluded the MMR immunization does not cause autism. That link has been thoroughly debunked.
A really important message.
It is, because the lack of vaccination, however, leads to a loss of that protective herd immunity and causes significant morbidity and mortality worldwide from serious complications of these diseases, things like pneumonia, croup, and encephalitis.
Such a vital point about the ongoing importance and safety of vaccination. And as you mentioned, measles or rubeola is the M in the MMR vaccine, and it brings its own, often more serious, set of potential complications.
It certainly does. Measles can lead to far more serious outcomes, either from the primary viral infection itself or from secondary bacterial infections that take advantage.
Like what kind of infections?
Often things like otitis media, that's ear infections, and pneumonia, commonly caused by bacteria like group A hemolytic streptococcus or Haemophilus influenza. And then there's a rare but very serious complication: measles encephalitis, which is inflammation of the brain. While most children thankfully recover completely, a small minority can suffer permanent brain damage or even death. It's not a mild disease.
Definitely not.
And for students needing that definitive diagnostic clue, something really specific to look for before the main rash breaks out, you have to watch for Kuplik spots.
Ah, Kuplik spots. I remember reading about those.
Yeah, they're quite famous in medicine. They are these clusters of tiny white lesions, often described as looking like salt grains on a red background, that appear on the lower buccal mucosa, that's the inside of the cheek, opposite the lower molars.
Inside the mouth. Okay.
Right. They're a classic, almost pathognomonic sign, pretty much unique to measles, appearing a day or two before the skin rash.
Wow, Koplik spots. That's such a memorable detail for diagnosis, isn't it? A real aha moment in a clinical setting. Okay, now, in the spirit of making sure we cover all the key conditions from our chapter, let's maybe do a quick rapid review of a few other important pediatric skin conditions, just making sure we understand their key identifiers.
Excellent idea. Let's hit the crucial points for quick recognition. First up, impetigo.
Okay, impetigo.
This is a highly contagious bacterial skin infection, very common. It often presents in bullous, that's blister-forming, and vesicular forms. The absolute signature here is the bacterial toxins producing these characteristic weeping lesions that develop a very distinctive honey-colored crust.
Honey-colored crust. Got it.
Think honey-crusted and highly contagious. That's impetigo.
All right. So if you see that honey-colored crust, alarm bell should ring for contagiousness. What about staphylococcal scalded skin syndrome, SSSS? That name alone sounds pretty intense.
It is, and it's a genuine emergency. Also known as Ritter disease, SSSS is a severe staphylococcal skin infection where the bacteria produce an exfoliative toxin.
Exfoliative, meaning?
Meaning it causes exfoliation or shedding. This toxin actually causes the top layers of the skin to separate and peel off, almost like a burn, leading to the formation of painful blisters and bullae over large areas of the skin.
Wow.
This condition absolutely requires emergency care and immediate systemic antibiotic treatment. The key here is skin peeling off, looks scalded, urgent emergency.
Definitely not something to be taken lightly at all. Okay, moving on to some common fungal infections we see in kids.
Right, so now we're talking about fungal infections caused by dermatophytes. These are specific types of fungi that just love keratin, the protein found in skin, hair, and nail.
Ah, the ringworm fungus.
Exactly, they're commonly known as ringworm, even though no worm is involved. Specifically, Tinea capitis affects the scalp, often causing patchy hair loss and scaling. And Tinea corporis is ringworm on the body, typically presenting as those classic red, itchy, circular, or oval lesions, often with raised borders and maybe some central clearing.
The classic ring shape.
Precisely. So remember, dermatophytes love keratin. Think ringworm, scalp, or body.
Got it. And finally, let's touch on something that might really alarm new parents, but is actually completely harmless.
Ah, yes, that would be Erythema toxicum neonatorum. It sounds serious, but it isn't.
Right. The name is a bit much.
It is. This is a very common, totally benign condition seen in newborns, usually within the first few days of life. It's characterized by an accumulation of macules, flat spots, papules, small bumps, and sometimes pustules, basically red spots, little bumps, and maybe some tiny pus-filled lesions scattered around.
Okay.
The crucial thing for parents, and for anyone in a clinical setting seeing a newborn, is to remember that this condition spontaneously resolves all by itself within a few weeks after birth. It requires absolutely no specific intervention. It's just a normal, harmless part of being a newborn for many infants.
That's really important reassurance.
Definitely. So for this one, newborn spots looks maybe a bit dramatic, but no worries, it goes away.
Okay, we've just scratched the surface, really, but what a journey we've taken through these common pediatric skin conditions, from the complex interplay of genetics and bacteria and acne,
Right down in those follicles.
to the compromised skin barrier and that awful itch-scratch cycle of atopic dermatitis, the very unique viral signatures of molluscum contagiosum, and the historical impact and ongoing relevance of viral exanthems like rubella and measles.
And the importance of vaccines there.
Absolutely. And we also hit those rapid-fire identifiers for bacterial challenges like impetigo and the emergency of SSSS, those keratin-loving fungal infections, and the benign self-resolving nature of Erythema toxicum neonatorum.
Quite a range.
It really is. Each of these conditions, from the incredibly common acne to the potentially life-threatening SSSS, presents unique pathophysiology. Understanding these underlying mechanisms isn't just about memorizing facts for a test. It's about gaining truly empowering insight, isn't it?
It absolutely is. And this really raises an important question for you, our listener, especially as you navigate your studies or clinical practice. How do you move beyond just recognizing a rash to truly mastering the diagnosis?
Yeah, the next level.
Exactly. Consider how even seemingly minor details, the precise distribution of a rash on an infant versus an older child, the specific nature of a lesion like that little umbilicated papule in molluscum, or the presence of a unique prodromal sign inside the mouth, like Koplik spots. These aren't just observational notes.
They're clues.
They are critical clues, each pointing towards a distinct underlying pathophysiology. Developing that critical eye for these subtle but often definitive features, that's what can dramatically improve your diagnostic accuracy and ultimately your patient care. That's the real takeaway, I think, from diving deep into this chapter.
Wonderfully put. It's all about connecting those dots, those subtle clues, to build that comprehensive picture. Well, thank you so much for joining us on this deep dive into pediatric skin conditions, especially looking through the lens of your Understanding Pathophysiology chapter.
My pleasure.
We really hope this has provided you with invaluable insights and a clearer, more dynamic understanding of this vital and, frankly, fascinating area. Until next time, keep learning, keep asking those deeper questions, and keep diving deep.